Sepsis is common. Sepsis kills, and it's one thing that we are always worried about.
One of the barriers, I think, is fear.
What really helps in that scenario is having multi-professional simulation training.
Sepsis 6 has allowed everybody to be able to identify sepsis and get help quickly. So here's the situation. You've got a child in front of you. You've actually recognised they've got sepsis. They've got a fever, their blood pressure is going down, the parents are really worried, and at the same time your bleep is going off, but you've cracked the situation. You've actually spotted the sepsis. So the question is, what now? You've got important decisions to make. And you've heard about bundles of care, but what is a bundle? What can you do to save that child's life? Hello and welcome to our Paediatric Sepsis podcast series, brought to you by the Royal College of Paediatrics and Child Health and the team from the North. That's the Great North Children's Hospital, and today with guest speakers from Gateshead and London. My name is Emma Lim and I'm a general paediatric consultant at the Great North Children's Hospital. Today we're going to be talking about choices. How do you know what the best thing to do is? What is the evidence to back this up? And hearing about what it really feels like when you're faced with children with sepsis. So I'd like to introduce you to today's speakers. From just south of the River Tyne comes Dr. Sachin Mannikar, who's a general paediatric consultant at Queen Elizabeth Hospital, Gateshead. Sachin, you have something I always admire because I talk too much and too fast. And whenever I see you, you're one of those people who just emanate this wonderful calmness. And I've never seen you angry. I've never seen you raise your voice. And that's one of those skills that is like gold dust in an emergency. And one of the reasons that I wanted you to come and speak today is because it's like a reality check. What you experience is what most consultant paediatricians experience. And that's real life. And it's not always the same as what happens in big centres. So hello, Sachin.
Hi, Emma. Thank you for the kind words, and thank you for inviting me. It's lovely to be here. I'm really delighted I can be of help.
Tell me a little bit about where you work and what it's like.
As you rightly said, I'm just south of the river at the Queen Elizabeth Hospital, which is secondary care district general hospital with a level 1 neonatal unit. And in my day job, I'm a jobbing pediatrician, seeing anything from minor illnesses to looking after babies, and do have a special interest in allergy, with part of my role being involved with teaching and training.
Perfect. So tell me, in your day-to-day practice, what does sepsis mean to you?
Sepsis is common. Sepsis kills. And it's one thing that we are always worried about. Having said that, I think in my day job, on my regular acute on-calls, I'd probably be saying once in a couple of months that I tend to see somebody who's really sick. So sepsis to me means infection and a child who is hemodynamically compromised. So those two together, where you need the whole cavalry, and you go with everything that you've learned and apply in real-time mode, that is sepsis.
Perfect. And so one of the things that we always talk about when we talk about sepsis is how do we manage sepsis and how do we deliver a bundle of care? What does that mean to you when you see these children?
The biggest difference now is that you have a clear sense of urgency because evidence clearly shows that makes a difference. So a bundle of sepsis involves not only recognition, assessment, but actually taking investigations and treating. And all that has to happen in a certain time limited way.
I think you're right. And there is this really clear guidelines that treating children within 1 hour reduces mortality and morbidity. It kind of focuses your mind because an hour isn't very long. And I think that when you're sitting in, not necessarily in a resuscitation room, but just in a treatment room with a sick child, just getting fluids and antibiotics and cultures in an hour is actually quite difficult.
I think what has massively changed is the mindset for nurses, for our junior doctors, being able to raise the alarm bells, to be able to call our seniors is something which Sepsis 6 has massively enabled. It's given a voice to everyone, and people now can turn around and say, that's the guideline, that's the pathway. So you're absolutely spot on that it has changed and brought more focus and a sense of urgency. If you think about a child who is difficult to cannulate, 1 hour goes in a whisker. And when the clock is ticking, you sometimes end up thinking 1 hour is not enough.
I think that Sepsis 6 absolutely has allowed everybody, from parents to nurses to junior doctors, to be able to identify sepsis and get help quickly.
I think the biggest change to me is just the awareness that there are simple things that can be done. For example, checking a capillary gas, which gives you lots of parameters, including lactate. You don't need mega resources. Second is take some bloods. So as one of our juniors said to me once, the way I remember is, whatever you do, as in if you take something out, you put something back. So if you're checking oxygen saturation, give them oxygen. If you're taking bloods, you give them antibiotics, you give them fluid. So that's a nice way to remember that you're doing, it's a dynamic process.
Absolutely. I love that idea of taking something out, putting something back, because it's an active process at all times.
Follow the Royal College of Paediatrics and Child Health on Twitter at RCPCHtweets, or check out the hashtag #PedsRocks. This podcast was brought to you by MediSense Medical Education. Learn medicine differently through podcasts, games, videos, role plays and more at www.medisense.org.uk.
Sachin, tell me about the reality of delivering this kind of bundle of care in 1 hour. What are the barriers and facilitators to that?
The way I see barriers, if you think as a one single system approach, wherein you start from community or primary care right through to tertiary care, there are barriers all along, right from recognition, lack of recognition. It's picking them up. That's the biggest challenge. And that's why what I like about Sepsis 6 is having that senior clinician's view.
I think that's so interesting. So if you think about your biggest barrier to delivering a bundle of care of management for sepsis in a 1 hour, would you say staffing is your biggest problem?
Workforce is a mega issue. And to give you an example, if you as the senior most person and the nurses have to pick a child and manage it, you probably can get through a lot of those things within an hour. But if you imagine somebody who's fairly junior on, and there's compelling, contrasting pressures.
And I think this is a particular problem in a district general hospital, and actually for us as well, where there's only one senior person, so it only takes 2 sick children for you not to be in the right place at the right time.
That's absolutely right. Sepsis 6 allows people to focus on certain parameters and to go ahead instituting antibiotics within the hour if you have the skills. And I think it takes away, it has to be a medic to deliver the treatment. It can be a nurse who's skilled to cannulate a child, and then the antibiotics are instituted. So it doesn't have to be done by a senior person. You can actually optimize skills. So you could have a skill-based approach. And what really helps in that scenario is having multi-professional simulation training.
Sachin, one of the barriers I think is fear. Certainly with my juniors, we have a good protocol. They know what they need to do. But one of the things they do is they worry. So they worry, should I give the antibiotics? Perhaps this is just a virus. They don't mind giving a little bit of fluid, and they definitely never want to start inotropes. So I think fear of following through is a barrier for juniors. I think it's scary. One of the things everybody always panics about is getting access. There is never a time when, as a paediatrician, you don't worry about getting access. And as a consultant, I actually feel de-skilled. And I think that is one of the things that you worry about when you're coming to these rare cases. What's your experience, Sachin?
Teaching undergraduates is such a joy when you bring crunchy bars out to practice intraosseous needles. Or that's what used to be till we started getting proper SIM extremities to practice. So I think that's a great opportunity. It's like using a defibrillator. It's an underused skill. And I think it should be mandatory that most of us who are senior clinicians working in DGHs.
Actually, it's really interesting. We did a simulation on sepsis, and we didn't do it in resus. We did it at the Paediatric assessment unit in our hospital, and we got somebody to put an IO needle in. And because the drill had changed, they didn't know how to attach the drill. And when they got it in, they didn't know how to take the piece out or how to stabilize it or how to strap it in. And it was actually those really practical things. What connector goes on the end?
I think it's for seniors as well. If you think about it's an infrequent practice about starting inotropes, or at least that's been for a certain generation of pediatricians. Probably it might become a second nature once people are following sepsis 6 for nearly a few years now. So it should become a second nature that you should be able to use inotropes through a peripheral line. Historically, it was always drummed into us that if you have to give adrenaline, it has to be through a central line. Central line access in a DGH is a skill like gold dust. Only few physicians or clinicians from ITU possibly may be able to use it. So it's infrequent practice of something which can be life-saving. People worry, I couldn't agree more, people worry and fear about the complications of inotropes. And they can probably go through the first 5 steps, absolutely roll on, but they get stuck in the 6th. And probably 15 years ago, I might have been the same. There's a reluctance on the part of nursing team. It takes longer to prepare infusions, which itself is a barrier. And actually, we've tried to create tabletop exercises, which involves, as a part of SIM, where you just have to work on infusions, creating infusions and clocking it just gives some of these inexperienced staff that little bit of extra confidence. And it makes it absolutely worth the while when you have a real scenario that they feel comfortable to not only cross-check, but actually prepare it.
I think that's such a hot tip, just practicing making up infusions. And that's so true of antibiotics as well. We did a process mapping exercise where we found out our biggest barrier to delivering a sepsis bundle was that we only had one key to the antibiotic cupboard, and the one key was carried by one nurse. So when they went to the loo, it took somebody 20 minutes to find the nurse who had the key to open the door to get the antibiotics out.
Well, I'm sure we've all got lots of stories like those. I think the long and short of this is we need practice, especially in DGH setting. Things like aminophylline, things like salbutamol, things dopamine, adrenaline. Drugs that have got a lower margin of error, people worry about what if scenarios. Yeah.
So I think our take-home message is sepsis is actually rare. Because it's rare, we don't practice it. And the huge facilitator, the thing that can really make things better is practice and practice through simulation. I love your example of just practicing making up infusions. So simple. We also practice sepsis scenarios in every single area in our hospital. So we go around all the areas once a month. It takes us a year to get through every ward, but we do it because it's a rare thing that needs practice.
And do you have sepsis champions in those areas?
Not enough.
Because that is one thing that we have learned. If only we could have somebody who's really passionate about this area, where they can cascade training, they can rally people around and get them involved in doing things.
This has been really fascinating to talk to you, Sachin, and we could talk sepsis management all day long, but let's just pause and bring this episode to a close. In our next episode, we'll explore complex sepsis and refractory sepsis and think about what to do when fluids just aren't enough.
The Paediatric Sepsis podcast series was brought to you by the Royal College of Paediatrics and Child Health and Medisense, with support from Health Education England.